Hello, everyone, and welcome to the second day of the Towards the Lunar Generation workshop, which is the first MVA workshop dedicated to students and young professionals. Today, we have our second keynote, which would focus on lunar medical autonomy and medical needs of lunar activities. And with us, we have Dr. Chris Lenthart. He is an element scientist for exploration medical capability for the Human Research Program at the NASA Johnson Space Center. He's also an associate professor with the Baylor College of Medicine in the Center for Space Medicine and the Department of Emergency Medicine. And he is here with us today to share his insights on the topic I just shared. Chris, the floor is yours.
Excellent. Well, good morning from Houston. My name, as mentioned, is Chris Lenthart, and today I've been asked to speak with you about lunar medical autonomy, which is a topic that is particularly relevant to my work and one that we are very interested in at NASA. So I'm going to go ahead and pull up my slides and share my screen. And let me put these into presentation mode. Awesome. So the purpose of today's talk is to talk about deep space, which is where the moon is compared to our work in low Earth orbit at the International Space Station, and to talk specifically about the medical capabilities that are necessary for humans to explore deep space. And so the group that I work for, you can see at the bottom there, Exploration Medical Capability. Our job is to try and envision or advance medical system design for space exploration. And in order to do that, what we have to be able to do is we have to be able to make good risk-informed decisions. And the reason that that's important is because for our lunar exploration and eventually our Mars exploration, we have to try and ultimately predict all of the medical events that are going to occur before they happen so that we can plan for them accordingly. And so in order to do that work, the Human Research Program focuses right now on three primary areas. One is we use as many analogs on the ground as we possibly can to simulate some of the spaceflight environments and the hazards of spaceflight. And so you can see there a list of some of the different analogs that we use on the ground, including some in Antarctica, some isolation facilities in Russia or in the United States, as well as a laboratory that can try and simulate space radiation. And the reason we do that, quite frankly, is because it's the easiest thing to do, and it's the most cost effective as well. So the fidelity of the analog is lower, but the ease of use and the cost is also lower. So we can do more and more research on the ground in that respect compared to what we might be able to do directly in spaceflight. The next area that we use for this work is the space station, the International Space Station. And low Earth orbit is a great environment to test a number of different capabilities. And I'm going to talk to you some more about some of the tests that we're doing on the space station from the medical capabilities perspective. But ultimately, the space station is not deep space. And in fact, from an autonomy perspective, the space station is very, very Earth reliant. So the space station is not autonomous in most of its activities. And so our hope at NASA is that our Artemis missions, the lunar missions that we are undertaking over the next decade or so, we hope that those missions are going to allow us to have an even higher fidelity simulation of our deep space activities. And so we hope to be able to decrease our reliance upon Earth during those lunar missions. And we hope that being in deep space will allow us to better study some of the isolation and confinement challenges that come with space exploration, as well as the deep space radiation environment, which is inherently different from the environment that the astronauts on the International Space Station face. And then lastly, one thing that we have to know more about are the transitions between different phases of gravity. So right now on the space station, we have microgravity, which is essentially zero gravity. And then they come back down to Earth and they have full Earth gravity, or 1G. But the moon is 1/6 G, Mars is 3/8 G. And we need to know how humans respond to those transitions between different gravitational forces. And that's something that we have very little information on to date. So the Human Research Program's goal is to use the different analogs and the different available opportunities that we have to try and learn the answers to the questions that are going to enable us to ultimately get to Mars. So here are some of the Earth analogs. In the upper left, you see the NEK facility in Moscow. Then next to that, we have some of the Antarctica stations, as well as to the right of that, parabolic flight, which allows us to test a number of different capabilities in free fall or in zero gravity. Bottom left, we have the Hera module at the Johnson Space Center. In the middle at the bottom is the Envihab facility, where we can do bed rest studies and elevated carbon dioxide studies, looking at the brain and the eyeball and how those affect human systems. And then bottom right is the space radiation laboratory that we use, which can simulate, to the best of our ability, galactic cosmic radiation. The space station itself is an analog for deep space exploration. And so our hope to use the ISS for Mars and before that for testing out technologies and capabilities that will enable lunar missions is a very valuable asset, and one that we need to take more advantage of. And what you see there on the right-hand side are just a number of examples of the different types of research or technology capabilities that are being tested and developed on the space station. And then we get to our lunar missions. And what you see here is a graphic or a notional idea of what the initial capability of the Gateway space station is going to look like, which is going to be in orbit around the moon. And that is our initial foray into living and working in deep space for long periods of time. So the initial Artemis missions, and then later on, some of the sustained or extended Artemis missions are going to become increasingly complex and increasingly long in duration, and in the challenges of what the astronauts are going to have to perform, the tasks they're going to have to perform during their missions. And so we hope to use lunar missions as a stepping stone to our ultimate destination, which for NASA is Mars. And so the goal is humans on Mars, and how can we do that successfully? It's a very, very challenging problem. Some of the technologies to get us to Mars and even to land us on Mars don't even exist today or have not been tested today. But specifically, the technologies and capabilities needed to keep humans alive and healthy and productive in the space environment for that long also don't exist today. And so there's a lot of work to be done on the human system needs for a Mars mission. So how does NASA hope to do that? So our goal is to use the Artemis missions as preparation for Mars. And the analogy that I like to use here is someone who's planning to run a marathon for the first time. If I am not a marathon runner, so full disclosure, but if you imagine that the Mars mission is a marathon, you don't just get up off your couch and go run a marathon. That is doomed for failure. So what do you have to do? You have to train and prepare and plan for that marathon. And so We view the Mars as that training ground. We use the moon as the training ground for Mars. So this is where we're going to train and prepare ourselves. We're going to develop the technologies, and we're going to test and prove the technologies and the capabilities that we need for a Mars mission. And so the hope is that we will be able to do that in a stepwise progression. So what you see here on the screen is an example of that. And the steps you see here are sequential. So over time, we want to have more people in lunar orbit. We want to have more people on the lunar surface. And we want to extend the period of time that they spend in lunar orbit, and then extend the period of time that they spend on the lunar surface. And ultimately, at the very end, what we hope to be able to do is we can perform almost fully a complete Mars mission simulation. So we can have people on the Gateway spacecraft in microgravity in deep space for months at a time to simulate the transit to Mars. We can have them on the lunar surface for 1 to 2 months in a way that will simulate Mars surface activities. And then we can bring them back up into lunar orbit and keep them in deep space for another few months, which will simulate their transit home. And so ultimately, these extended Artemis missions are where we are going to test the human system and all of the human system capabilities and needs for the spacecraft and for the mission. What you see here are our examples of the different steps that we see that the moon helps us in getting to Mars. So one thing we have to learn how to do, quite frankly, is how to aggregate a complex ship, a complex spacecraft in deep space. So over time, we're going to have to put together our Mars ship. And that will likely have to happen in the space environment, and ideally in deep space, because it reduces the amount of propulsion that we need to get us to Mars. We need to be able to have a habitat in deep space that can function for years at a time. And that can be self-sufficient. It can have all of the resources, all of the oxygen and water and food and medicine necessary to simulate a Mars transit and ultimately to be that vehicle that goes to Mars. We want to do repeated orbit to surface operations and transitions over time, not only to test landing capabilities and different technologies, but also to see how humans respond to those different transitions in G forces or in gravitational forces. Ultimately, what we would love to do on the moon is find a way to refuel and resupply our operations. So for example, if we do find a substantial amount of water on the lunar surface and we can use those resources in situ, we can develop oxygen for the astronauts to breathe, as well as hydrogen and oxygen, which can be used as a variety of different types of rocket fuels. The last one you see there, crew health and performance, is very much where my group works. And our job is to try and identify how the human body is going to adapt and respond in deep space, and how we can develop the countermeasures and treatments necessary to keep people alive, healthy, and performing at a high level in those longer and longer lunar missions. On the surface, we're going to have to advance our spacesuit capabilities beyond where they are today. We're going to have to learn how to live and work on the go. So ideally, we're going to have a pressurized mobile habitat that the astronauts can live in for days, if not weeks at a time. We're going to have to learn how to protect the moon from us and us from the moon, and ultimately use that knowledge to do the same thing for Mars. We want to expand our capability to hand in hand perform exploration using robotics. And so oftentimes people say that robots are better than humans, or people will say that humans are better than robots. But ultimately, the right answer is both. Humans and robots working together are much more efficient than either one independently, because the humans and the robots have different capabilities. And then lastly, we want our astronauts on the lunar surface to perform well and stay healthy in that partial gravity environment. And we have, as humanity, we have really limited data on how people live in a partial gravity environment. And so there's a lot of work to be done there to better understand what risks that poses, as well as how we overcome some of the challenges associated with those risks. So what are the primary hazards of exploration spaceflight? And so you see them here. These are the ones that we focus on in the Human Research Program. And we remember them with the acronym RIDGE, which stands for radiation, isolation and confinement, distance from Earth, gravity fields, and the environment itself. And so within exploration medical capability, the one that is of most interest to us, or the one that we focus on the most, is distance from Earth. And as we increase the distance from Earth, we have to fundamentally change the way that we approach medical risk as opposed to what we do today on the International Space Station. So on the ISS right now, we have missions that at most last up to a year, but most are 6 months. We send resupply vehicles to the space station almost monthly now. We have 24 hours a day, 7 days a week, real-time communications with the space station. So anytime the astronauts have a problem, or anytime the ground wants to share information with them, they can speak in real time and relay that information instantaneously. With our resupply capabilities, we also have regular sample returns to Earth. So if someone were to become sick and we wanted to test their blood, and we didn't have to return them to Earth, we could just bring a blood sample home when the next ship comes home, and we can do tests on the ground on that blood, for example. We also have the possibility to emergency evacuate anyone on the space station and have them on the ground, on Earth, and in a hospital within hours, maybe a day at most. And so that very much drives the way that we think about medical problems on space station. And as a result, we have limited onboard medical care on the space station because we are very reliant upon the ground. If something bad happens, we simply plan to bring someone home. However, our exploration class missions, as their distance from Earth increases, their complexity increases from a medical risk perspective. And so what you see here are longer missions with no resupply, with no real-time communications, with no sample return, and with no evacuation. Now, on the lunar surface, evacuation is a possibility, but if you imagine or envision the way that the Gateway spacecraft is going to orbit the moon, it's only going to be in position once every 7 days to meet a vehicle from the surface. And as a result, if someone goes down to the lunar surface and 2 days later becomes sick or injured, it could take up to 5 days for the Gateway spacecraft to be back in place. They would then have to leave the lunar surface and go to the Gateway spacecraft. And then they would have to get into the Orion spacecraft and they would have to come home. And so that evacuation could take up to 10 days. And if a serious medical event is occurring, 10 days is a lifetime. So we have to think about future missions as having less and less possibility of evacuation until eventually when we're going to go to Mars, in which point evacuation is completely impossible. And so the challenge that we have in the future is that if we have limited onboard medical care and we're reliant upon the crew or the vehicle to provide that care because we can't bring them home again, then we are going to be in a challenging place. And so we have to try and change that paradigm. What you see here are some of the risk drivers for medical system needs. These are the things that we look at on a daily basis when trying to plan and envision how we will advance medical system design. And we have to take these drivers into account as we increase the complexity of the system. But an increasingly complex system that the people on board are not trained to use or have not had sufficient time to prepare to use is not going to be successful. And so ultimately, over time, what we have to do is we have to better prepare the crew to function independently. And so essentially, our plan for the future is to consider exploration class missions as ones that require progressive Earth independence or increasing crew autonomy. So what that means is we want the astronauts on board the spacecraft to be able to perform their own analysis and diagnostic capabilities in case someone becomes sick or injured. We want to take all of our crew health systems and integrate them with the vehicle in a way that allows us to reduce our need for our footprint in terms of mass, power, and volume. We need to plan in advance before they go for them to have sufficient medical supplies and for them to have all of the things that they are going to need in advance of going. So we have to predict all of their needs before they go. And then we have to empower the astronauts on board with the knowledge, skills, and abilities to manage their own health conditions without having to come home again or without having to talk to the ground. So that progressive Earth independence is fundamentally different from the way that we perform current medical operations on the space station. We have to have in situ analysis. We have to enhance our ability to perform medical procedures in mission. We need to help the astronauts to make good medical decisions by giving them advanced computing tools that will enable them to do that. And we need to find new ways to use our onboard resources in a way that improves our efficiency and minimizes our need for resupply. And so the examples I'm going to give you now fit into all of these categories and are a good view of the work that exploration medical capability is currently doing. All right, so let's talk about in situ analysis. So what you see here is Dr. Kate Rubins, one of our NASA astronauts, and she is using a white blood cell analyzer device on the space station in a way that's never been done before. So if you get sick or injured on the ground and you go to your local hospital, one of the most likely tests that any doctor will perform is a white blood cell count. It's a white blood cell count and a differential looking at the different types of white blood cells. That capability has never existed in spaceflight. We have never been able to do an in situ white blood cell analysis in spaceflight until a few months ago. And that's when we took a device, which is a commercially available device called the HemaQ device, and we used it in space. And first, what we did there is we used a series of control solutions to see if it was giving us accurate numbers. And the first time we tested it, it totally didn't work. And it didn't work because our procedures were wrong. And so we had to go back on the ground, rework our procedures, and then send them up to the space station. And they did another trial with the device, and it worked very well. And then after that, we got a bonus test when we had one of the astronauts put some of their own blood into the device. And we were able to get back accurate readings from that device. So this was the first time ever that we have performed real-time hematology studies on the space station. And this capability could be essential for a moon mission or a Mars mission to help us diagnose illness or to monitor and track radiation exposure or to see how successful one of our treatments might be in case an astronaut has an infection. And our hope is that over the future, we can successfully integrate this kind of capability on the space station or in the Artemis missions so we can learn how to use it well in an autonomous fashion before we go to Mars. The next example I'll show you is a more robust point of care blood analysis device. The one that we are testing right now is called R Health One. And this is a device that was developed through some small business innovation research grants from NASA, as well as other government agencies. And this device is an integrated blood analyzer, as well as a vital signs sensor. So the idea, again, is how many capabilities, how many technologies can we fit into a smaller and smaller footprint so that it takes up less space, less mass and volume on an exploration mission. And so this device uses cytometry. It also uses nanostrips and light levels, and looks at all of the different, we hope over time, looks at all of the different analytes that you see there on the screen. And many of these are commonly tested blood tests that we perform in the hospital when we're taking care of sick or injured people. The last example that I want to show you here is a little bit different. This is the possibility of performing real-time medication stability assessments. One of the things that we've seen in some of our studies in the past is that medications that are flown to space seem to degrade or break down faster than medicines do on the ground. And in fact, that's a serious challenge, because for a Mars mission that is 2 to 3 years in length, if those medications degrade to a point where they're either ineffective, or if while they degrade, they actually create toxic byproducts, then giving them to the astronauts means that they may not get better. And in fact, they could get sicker. And so what this capability could do is it could allow us to real-time test medicine in space to know that it is safe and effective to use before we give it to the astronauts. And so this device uses a Raman spectrometer and an indexing mechanism to align pharmaceuticals for analysis. And this is an example of a capability or technology that we could include in our future medical systems so that we can have confidence that the medicines are going to work the way we believe they should when we give them to future astronauts. All right, so that was a summary of some of the in situ analysis, testing, and work that XMC is doing right now. The next one I'll talk about is medical procedure support. So most of the astronauts who go to space station are not doctors. And as a result, when they are asked to perform medical tasks in flight, it can be pretty stressful, and they may require real-time guidance from the ground in order to do that. What we wanted to do was develop a software platform that could help the astronauts to perform complex medical procedures with limited to no ground support. And so the AMOS software was our work in this area. And it's a tool that we hope could be used before they go on a mission to train them for the mission. They could use the software in mission to do either just-in-time training if they have to perform a procedure right now, or as regular refresher training if they're trying to maintain their skills and competence. Or the last part is that we hope that they would be able to use it real time as guidance during the medical procedure without having to talk to the ground. And so what you see on the right-hand side is an example of one of our NASA astronauts. That's Jessica Meir, and she is performing this study for us. And what she's doing as she's performing this study is she is not talking to the ground, and she is not a trained ultrasound provider. So she is fairly new to this technology. She got access to the software the day before she used it. And she was able to successfully capture high quality medical use ultrasound images of the kidney and the urinary bladder without talking to the ground at all. And so this was the first time that we have ever performed completely autonomous ultrasound on the space station. And it was a great demonstration that with the right tools and with the right support, the astronauts can perform complex medical procedures without having to talk to the ground. What you see here is an example of what the software looks like and how it guides the astronauts through performing a procedure. And over time, our hope is that we can make additional modules that will use this platform and perform additional medical procedures in spaceflight autonomously until we reach a point where our normal operations may be for the astronauts to perform these kinds of tasks independently, and the ground is just there to help in case they need it. So that's an example of medical task or procedure support. Now I'll share with you a little bit about our early work on what we call clinical decision support, or CDS. And this is very early work that we are doing at NASA, but our objectives, our goals are to develop the requirements for an in-mission integrated crew health and performance data architecture and clinical decision support system. Right now on the space station, every piece of medical information and data that they collect on the astronauts does not get stored on station. It gets transmitted to the ground and stored in software and in databases that are ground-based. And so the astronauts don't have access to their own data. And there's no data integration on the vehicle. And as a result, there's no data analysis on the vehicle from a medical perspective. And so our hope is that future missions like Artemis missions and lunar missions will be able to have an integrated crew health and performance system that has its own data architecture so that all of the health and medical data that's captured on the astronauts is stored on the vehicle. And then on the vehicle, we can use computer systems to perform descriptive and advanced analytics on that data, and then give the astronauts tools to use that data real time to make medical decisions. And so our hope is that we can increase the ability for the astronauts to make their own autonomous medical decisions without being reliant upon ground information or the flight surgeons on the ground. This is just an example of how we are envisioning this to occur. The first step, of course, is to gather good and relevant health and performance data, to store it in a way that it's useful to the astronauts, and then to have a series of analytics and decision models that can help them to interface with the system and make good decisions. So if an astronaut, for example, were to develop a headache on space station, they should be able to access the crew health and performance system. They should be able to see all of their own personal health information, their nutrition, their fluid levels or fluid intake levels, their sleep, onboard carbon dioxide levels, all sorts of vehicle and personal information that can help them to make a good medical decision. And then they would have these decision models, which would help them to come to the most likely diagnosis and identify the best potential treatments. And so there's a significant amount of work going on the ground, on Earth, in terrestrial medicine, in these kinds of decision-making tools that can help physicians and people on the ground to make better medical decisions. We want to try and push these same decisions into space for the astronauts to use. So clinical decision support is important for increasing the autonomy of the astronauts. But another thing that we have to do on our lunar missions is we need to find new ways to use the resources that are available on board. And so an example that I'm going to show you here is what's called IV Gen. and it's an intravenous fluid generator that takes drinkable water from the space station and turns it into sterile fluids that we can give through an intravenous line to a sick or injured astronaut. Right now, we fly IV fluids to the space station in individual bags. And those bags, if they're not used, are wasted. And those bags have limited shelf life. So if they aren't used by a certain period of time, they're wasted and we have to send new bags up. And that's obviously perfectly acceptable for a space station because we have nearly constant resupply capabilities with space station. But for our deep space missions, that's a lot of wasted mass and volume if we have to send all these bags of IV fluid that may never be used or may expire before they can be used. And so the goal is to be able to develop a system that would allow us to real-time make IV fluid in flight and recycle all of that water, if not used, into the water reclamation systems so that we can continually reuse our resources and not waste anything. We've previously done a technology demonstration on space station showing that this capability can work. We can purify the water and remove all the bubbles. We can sterilize it. We can mix it with the salts that need to be in it for it to be given as IV fluids. And we've shown that it can be compliant with ground medical standards. So what we have to do now is we have to miniaturize that capability that you saw, and we need to integrate it fully into life support systems. And so the goal there, again, is to reduce our resource footprint from a health and performance perspective on exploration missions. The smaller we can get and the more integrated we can get with vehicle systems, the more capabilities we can essentially fit on board these smaller and smaller spacecraft that go into deep space. So what I've shown you here are three examples, more than three examples, but there's three primary examples of the types of exchange that we want between the kind of technologies and capabilities we have on Earth and those that we have in space. And I believe that many of these can be tested on the space station and then incorporated into lunar missions, not only for operational use, but for further development and refinement so that we can ultimately perform longer and longer lunar missions and then Mars missions. So we can take devices that are purely developed for commercial purposes on the ground, and we can use them in space with little to no modification. And so the white blood cell analyzer that I showed you is a good example of that. We can use a hybrid approach, which is where we try and develop something for the ground, but also for space concurrently. And so the point of care blood analysis device that I showed you, its development and its requirements are based on space needs as well as Earth needs. Or we could develop capabilities like the autonomous medical officer support software and the IV generation experiment. We can develop those capabilities for space applications, but then it's also very easy to see how those would be terribly useful on the ground. If any hospital or any place in the world could develop IV fluids from any potable water source, that has tremendous uses all around the world. So in summary, the Human Research Program is developing autonomous medical capabilities that we hope to use on the moon and ultimately on Mars. In order to do that, there's many steps we have to go through along the way in order to get the buy-in from all of the people that we need to make these successful. We need to do ground development and testing. We need to show that new ways of performing medical protocols and procedures can be done in a way that is increasingly Earth independent. We need to then deploy these capabilities into some of our analog environments to prove that they are working well. And then we need to show through demonstrations in the space environment that the technologies and capabilities work and that they can improve the health and productivity of our astronauts. And then ultimately, we want to transition these technologies to regular operations for our deep space Artemis missions, and then ultimately for Mars. But the ultimate goal is the integration of these Earth independent capabilities into future vehicle systems. And so an integrated crew health and performance system is our vision for the future. And with that, I will end here, and I will happily take any questions or discussion that we may have.
Thank you, Chris, for the great talk. I'll just remind everyone that is watching, if you have any questions, you can put it in on YouTube in the chat or in the Q&A on Zoom. And we already have 3 questions. I'm going to read them to you. Mark is asking, does IVGen have the capability to make different IV formulations, like 3%, 23% for neurological emergencies?
That's a great question. That's our hope. Our initial test unit that we built only made normal saline, but the goal going forward would be that we would be able to make not only different concentrations, but maybe even different fluids. So whether it's normal saline or whether it's lactated Ringer's solution or any number of different possibilities, we would hope to be able to have the capability be flexible enough to make a variety of different solutions. So the answer to your question is yes, that is what we hope to have in the future. And our new unit that we're developing, some of the requirements for that unit are to be able to make different solutions.
Great. Alexandra is asking, if funding and scheduling was not an issue, what experiment do you want to perform on the ISS?
That is a great question. Funding and scheduling are always an issue, but if they were not, one of our hopes on the ISS is there's an ongoing effort called ISS for Mars, and that is where we are looking at performing a number of different technology demonstrations on space station. And the one that we hope to perform from exploration medical capability would be a simulation of a complex medical event that does not get evacuated and that the crew has to handle either fully independently or mostly independently. And so what we're looking at there is a 1 to 2 day simulation where they would either have no comm or they would have time delayed communications, and they would have to simulate and perform a number of different complex medical tasks and procedures on one of their crew members who was in simulation, sick or injured, and they would have to do that for a period of a few days. And right now, the ability to perform that simulation is limited for a number of different reasons, but it's on our wish list and one that we continually push for using the ISS to simulate a deep space mission. I guess
it's very similar to this question, but it maybe from a different analog perspective. So you talked about the different analogs and how you use them in simulating medical events. I guess what are major challenges in simulating lunar medical events? Because obviously they're different from the environment you would have on ISS or on the Earth or other places, right?
Yeah. I think that one of the reasons that we in the Human Research Program are so interested in using Artemis to prepare for Mars is because we believe that there are capabilities and tests that we can do on the lunar surface that frankly you cannot do anywhere else. And the reason for that is the partial gravity environment. So even if we use Antarctica or we use a medical simulation laboratory at a university, or we use the space station, the one thing we can never simulate for more than 20 seconds is 1/6 G. And we don't know how that's going to affect human systems. So how your anatomy and physiology and psychology are going to be affected by that partial gravity environment. But we also don't know how our technology is going to work. It's a nice thing to assume that if it works in 1G and it works in 0G, that it's going to work in 1/6 G. But we've been shown wrong when we have assumptions that things are going to work in space many, many times. And so the complexities of that partial gravity environment are something that simply cannot be simulated anywhere else other than in a partial gravity environment like the moon or Mars. And so our hope is that once we have people on the lunar surface, we will be able to test some of our technologies and do simulations that use new protocols and procedures in a way that demonstrate that the partial gravity environment will still enable our technologies and capabilities to work effectively. And I think it's one thing to say that if it works on Earth and it works on the space station, it's going to work on the moon. I think we have moderate confidence probably in that statement. However, if you say it works on Earth, it works on the ISS, and it works on the moon in 1/6 G, I can now say with pretty high confidence that it's going to work in 3/8 G on the Mars surface. And so the ability to use the lunar surface for testing technologies in partial gravity, I think is essential for the confidence that we're going to have in our Mars medical systems.
And you just touched on technology, so I'm going to move on to technology questions because we do have a working group that focuses on that. Dan is asking, in what way do you envision that 3D printing or regenerative medicine will be integrated to become medically autonomous?
That's a great question, and I think that the challenge is we still don't use 3D printing or regenerative medicine regularly on Earth for our medical purposes. And part of the reason that we don't, frankly, is because in many cases, resupply is not a difficult thing. And so I don't have a 3D printer. When I go work a shift in the emergency department in a large hospital in Houston, there's no 3D printer in sight. So I can't make anything I need. I have to have it in stock. And so oftentimes we transition technologies from Earth into space. But in this case, some of the capabilities that we're developing for spaceflight are so unique that we're not really using them regularly on Earth. My hope is that we can use 3D printing technologies, especially for a few of the things we've actually already demonstrated in spaceflight, which are things like splints for injuries. So a finger injury or a wrist injury, you should be able to easily 3D print a splint to help treat that injury. And you can make that splint specific to the astronaut that you're using it for. Where it gets a lot more complicated are the 3D printing of other kinds of medical consumables. So one area that's of interest to us is whether or not we can print medicine. And so we have a joint university funding activity at NASA that's looking at using 3D printing to make medication at the time that you need it. So that's one capability that's particularly interesting to us in the future. Another one, of course, is related to, it's not medicine per se, but it's the 3D printing of food. And can you make palatable and nutritious food that astronauts will want to eat from some common supplies? So essentially, you wouldn't have to stock things like you would in a food system on space station today, but you would have these substrates that you could build from to make nutritious food. And perhaps that food would be able to last longer and not expire in the space environment. So using 3D printing and other capabilities like that to make medical supplies when we need them is certainly something that we're interested in the future, but it's still very much an early technology from a medical perspective.
The next question is about not so early medical technology. Aaron is asking about the clinical decision support system. They want to know if this has a medical database installed for the first stage of the automation, and if in turn this is supervised by a medical team on the ground to support diagnosis and treatment.
A system like that would absolutely have to have a medical database built into it. And right now we have a team on the ground that is developing a medical evidence database for our work, our research within exploration medical capability, but it's not specifically a medical database that would power a future clinical decision support system. And so our belief right now is that the application of clinical decision support in spaceflight is probably 5 to 10 years away. And as a result, we don't really want to install a medical database of today into our system because that medical knowledge will change over time. And so ultimately what we hope to do is we hope to develop the requirements for a clinical decision support system that say what the database should look like and what it should contain, but that we want to leave the actual building of the system and the inclusion of the database to people in the future when they can do it using newer information that is more relevant or more up to date by the time it's going to go into use.
I guess to add to the question, I know that in a couple of years ago, for example, the Canadian Space Agency was testing I think it was exoskin, something like that, as a continuous monitoring tool. Do you foresee that continuous monitoring tools would play a role in the context of this decision support system?
I very much hope so. That's our goal. That's our intent. The challenge that we have right now with these continuous monitoring systems, and I'll be honest, I'm wearing one right now. I got my Fitbit on and it's monitoring my heart rate. The challenge that we have is we as humanity don't know what to do with that information. So sure, my Fitbit can tell me what my heart rate is. It can show me what my resting heart rate is, but it doesn't tell me how to fix it or improve it. If it does, it just gives me some platitudes like get some more sleep or go exercise more, but it's not specific. What we need to be able to do with a clinical decision support system is we need to be able to real-time analyze all of this continuous health monitoring data. And we need to be able to identify when things are going poorly and exactly what we need to do in order to correct those problems before they actually become real illness or injury. And that's the step in continuous health monitoring that doesn't even exist here on the ground yet. All we're doing is collecting reams of data, but we still don't know how to use that data. Ultimately, clinical decision support should learn how to use that data in a meaningful way to help the astronauts to make better medical decisions.
And I guess this clinical decision support tool right now, I suspect that it's mainly focused on physical health. What about mental health? Because that's something that's also affected a lot when we think of the isolation on the moon.
Absolutely, and it's a really good point that we don't specifically mention enough. When we created our concept of operations for our clinical decision support system, we specifically included scenarios that had to do with behavioral health and psychological health. And so our hope is going to be that when we develop prototypes for this system and requirements for this system, we're going to build into it from the very beginning the ability to monitor psychological and behavioral health and to develop countermeasures or incorporate countermeasures or capabilities into the system that will enable us to improve on that psychological health of the astronauts. And so right now we perform regular private psychological conferences with the astronauts where they talk to people on the ground about their needs and their feelings and how they're adapting to spaceflight. And they get real-time ground support in that area. Over time, we're going to have to develop some more autonomous capabilities that do the same things as those private psychological conferences, and hopefully incorporate that technology into a clinical decision support system. And so the need to do that has been defined in the vision for the system. Exactly how we're going to do that still is undefined.
Okay, so the next question, let's shift away and look broadly at technology, I guess. What are some of the core technologies that need to be developed along the lines of connected humans, such as biosensors and suits, that can catch problems before they happen?
I think I'm going to come back to the point I made before, which is that there are many, many different tech companies on the ground right now that are building all kinds of sensors and devices for gathering all this information. But what very few people on the ground are focusing on right now is, how do I use that information in a meaningful way? And so we, as humanity, seem to love our technology, and we love data, and we believe that more data is always better. But yet we don't know how to effectively use that information. And so I would wager that the most important thing that can be done now, or the area that's underdeveloped right now, is that analysis of the data and use of the data to make it meaningful. In deep space, especially, we have data storage challenges. So if you're continually gathering information on the astronauts and you're storing tons and tons of data on every one of these astronauts every second of every day, you are going to quickly exceed the storage capabilities of what we have on board. What we're going to need to be able to do is collect that data, periodically analyze it, and if nothing interesting happened during that period of time, we need to delete that data and then start capturing new data going forward. And so it's that ability to look at it real time, the data, and identify what we can do about something or what pieces of data are meaningful. That is the part of the equation that is currently missing.
Do you foresee the role of the medical officer and the patient changing as missions become longer and deeper in space?
Yes, absolutely. And I think that all you have to do is look at a movie like The Martian to think about how this happens. So there may only be one person on board who's trained as a crew medical officer. If that person becomes sick or injured, who's going to take care of them, or who's going to take care of the rest of the crew? If the person becomes sick or injured and there is no crew medical officer around, how are they going to take care of themselves? So we need to enable the crew members to become more adept at their health, at their own health and medical treatments. We need to empower the crew medical officer to be more in charge of the crew's overall regular health. And in order to do that, what we have to do is we have to take some of the responsibilities on the ground of the flight surgeon who takes care of the astronauts, and we need to push those responsibilities into space. So we need the crew medical officer to be more independent, but we also need the crew members themselves to be more medically knowledgeable over time, or we need to give them the tools to help them make good medical decisions in the event that the people who are trained, like the crew medical officer or the ground, are unavailable.
And the last question for today is, what is the one medical complication or condition that needs to be fully fleshed out and understood to truly be able to operate on the moon?
That is the hardest question, of course. So I appreciate that you left it to last. But I will say honestly right now that we tend to get, I'm going to say we tend to get fixated upon those ones that we see right in front of us right now. And so a lot of people focus on challenges associated with space radiation, or they focus on space-associated neuroocular syndrome, or SANS, which is the changes in the eyeball and the brain that may be from fluid shifts in spaceflight. But the reality is that sometimes it's the simplest things that are the most complex. And so one of the things that we're doing in exploration medical capability right now is we are working on using probabilistic risk analysis to predict the most commonly occurring medical events and the ones that have the most consequence for the crew. And the things that keep coming to the top of that one are not necessarily complex problems. So there are things like rashes. Rashes are super annoying to the crew and affect their health and performance in a number of different ways, but are not necessarily complicated. The one that is of the highest consequence, which occurs most commonly in our modeling, is sepsis, or a blood infection. And so the ability to monitor and test for infection and to treat infection before it becomes severe is a top priority for us in exploration medical capability, because time and time again, when we run our models, it's those infections that come to the top of the list. And in fact, it has occurred in spaceflight before. Apollo 13, the astronaut who got sick on the way home on Apollo 13 had a blood infection. And the only reason that he survived was because they were coming home to Earth and he could be treated on the ground. So it's not always the thing that is the flashiest, but these are the things that affect humans the most often.
Great. And thank you again for joining us today. Thanks everyone for joining as well. And thanks for answering all of these questions. It was a great overview of really what NASA is doing towards improving medical autonomy in space.
Thank you. It was a pleasure being here.
And with that, we will close the live stream and close this call. Thanks a lot, Chris. Thanks a lot, everyone, for joining.